Okay, so how this philosophy changed the way you do your ortho? Because as I know, you've been Damon dentist for many years. Before
Okay,
that,
I was, before I was Damon, I was, originally trained in Edgewise, okay?
Okay.
And then after Edgewise, it was straight wire, then it was bioprogressive rickets. For a long time, I was looking for something to treat my patients better because I had too many relapses in the office. I've always
many
been a very
relapses orthodontically, you mean, right?
orthodontically. I've
Okay.
been very active. I'm a 100% clinician, so I've always had a very strong patient office, and so which means that working a lot, you have a lot of successes, but then you have a lot of failures too. Everybody has failures, and I had more failures than successes in the office,
Okay.
because I would see these patients coming back after 2 years, 5 years with a lot of relapses, especially my class 2s. My class 2s were a disaster.
Okay.
So I started questioning myself. I said, what am I doing wrong? So I left my comfort zone, and I was looking for something better for a long time. So that's when I switched for self-ligation, and then I switched so I had been switching what I was doing for a long time. I was an international lecturer for a company for brackets for a while. So, and then mini screws, I went all the way to Taiwan to be trained by John Lin and Chris Chang. And then I went with the Germans. So I went all over the place, really trying to get better and find a better way to treat my patients. Something that worked, right? That made sense. Because what I was doing, that I was taught from the university, and then what I was doing with that was written in the books was not working for me.
Okay.
So orthodontically, it changed completely. It wasn't just Slavicek, it was Sato and Slavicek. So it's the combination of Professor Sato's concepts and Slavicek's concept. And I can tell you, it was 180 degrees. It was flip the coin, literally. It was change the avatar. It wasn't change the chip.
With 2 words, what was actually the game changer in you? What actually was the fundamentals? The fundamental thing that you change maybe in your diagnosing, and later on followed by what did you change in the treatment?
One word, function.
Function.
I had no idea what function was. If I don't know what a good function is, how can I know what a dysfunction is?
Okay. So do you mean that we can have aligned teeth and then we can still have a bad function?
Oh yeah. You can have a condyle center in the fossa and a very, very sick joint. You can have a patient that says he's pain-free and have a sick joint.
Okay.
And it doesn't, dysfunctional. And you can have a symptomatic patient that the joints are crap. So they say they are asymptomatic. People just don't know how to diagnose. So they have other comorbidities. They have other pains, not just articular pain. So the game changer was function. And Professor Slavicek was a genius, because I'm an ortho. As an orthodontist, I can put teeth wherever I want. And that's what I was doing. I was moving teeth so the smile would be beautiful. But the problem is, teeth do not do function. The articulations do.
Okay.
And I wasn't even looking at the articulations. I knew nothing about articulation.
Let me ask you a quick question. Is when you ask your patient, does the patient has a pain, or if the patient has a clicking joint, do you think this is enough information to know if the patient is functional or dysfunctional?
No, never.
What more do we need there?
Oh, you need quite a lot of things. It's first of all, you have to observe your patient, the way he speaks, the way he moves the mouth. His eyes tell you a lot, because it's all connected, right? And then you have to at least tell your patient to open and close the mouth. Open and close. If there's any deviation, you can be sure there's a problem.
Okay.
because open and closing should be straight. So nobody's doing that. So asking questions not enough. I walk the whole mile. I do all the functional and all the static, so dynamic and static exams. I
Yeah,
do everything.
this is very good that you said, because occlusion is not only static, it's actually a lot of dynamic movements that we need to be aware and we need to check. And also sleeping, and when the patient are bruxing, it's also very important, right?
No, it's 100% important. So, I mean, honestly, the way that I used to do ortho before was completely wrong. All I was doing was looking from outside. I always trace my steps,
Okay.
but that's it. I wasn't, the panoramic was just to count how many teeth and if there are any supernumeraries. I never looked at anything else. I was just very wrong. I had no idea what function was.
Okay.
So I was looking at the chocolate side, the buccal side, which is looks beautiful. Great. You know what I used to do? I used to tell my patient, bite. Patient would bite. I would look and say, great, everything is fitting, braces off. I didn't even tell the patient to move the mouth.
Okay.
So
So
my pictures on Instagram look beautiful, but it was really bad work. Well, it wasn't bad work. I didn't know any better. Nobody taught me.
it was deeper things that you need to learn and to apply, right?
Oh, I had no idea, and nobody taught me.
Okay, so do you have any case that maybe you can share with us that it can be interesting? I don't know. It's something that you can share a screen and maybe just scroll through some diagnosing thing, because I think it's very important if somehow you show what are the necessary things that you are getting from the patient as information, what exams you are doing, so we can, I think I need to give you the permission to share. Okay, now you can, maybe you can share a screen.
Let me see. Desktop, yeah, share. So I have to, where'd it go? Okay, maybe here.
Okay.
Okay.
And this is very good because I didn't prepare you to show any case, so you go directly. That means that you have a lot of
Like
material.
always, Ronaldo, you never prepare me. Dani, show something. I'm like, where? So off the top of my head, it's because I do carry everything on external hard drives. I happen to have this case here on my computer. So I work the way that I work also side by side with a chiropractor. So I treat my patients in a very, I don't like the word holistic, but it's the correct word, in a very integrated or integrated way. So the whole body. So this is a descending lesion. This is a beautiful girl, young. She's only 17. She has been treated. She has had ortho, right? Very, very, really extremely beautiful girl. She comes in and she says, I don't like the position of my teeth. So she did not like her smile. She didn't like her smile. She has pain in the masseters when waking up. This is a very important part, is the questions you ask your patients. To get the history, your patient will tell you everything. So I don't like my teeth. I have pain in my masseters. When I wake up, I feel like my jaws are locked. So when she wakes up immediately, it's like she's biting so hard she can't open her mouth. Then she has to massage her cheeks to be able to open. She feels that she grinds during sleep and she snores. She has a lot of occipital headache, and then it comes from behind all the way to the temporal region 4 times a week. This is a 17-year-old that takes pain medication 4 times a week. This is ridiculous. So, and strong pain medication. And then she takes Torsilax, which is a muscle relaxant with a painkiller for the neck and shoulders. And it got worse 1 year before she came to me. So she's taking painkillers for the headache, occipital headache, and painkillers for shoulders and neck, right? And sometimes she has torticollis. So she's either locked to the right or locked to the left. She has thoracic spinal pain.
Okay.
And then she's always tired from chewing foods, very tired. And she has an audible click on the right joint. So this is everything that I got from her. She has picatus asymmetry, and she refuses to wear braces for that because her sister wore braces for years and it didn't correct. Her sister also has picatus asymmetry. She's hyperlaxic, loose ligaments. She has anxiety attacks. She's a perfectionist. She's been in therapy since she was 8. So a lot of psychosomatic behind it. Good quality sleep, so she says. And she wakes up with dry eyes and dry mouth. And she sleeps with a removable, this is ridiculous, a removable braces. After she finished a Clement. She finished ortho for 2 years. When I go to palpation, this is just by asking her, never articular pain, ever. She has occipital pain here that goes to the temporal pain, but temporal muscle, and neck, shoulder, and neck.
Let me just give a little bit of information. So here, after you ask all of the questions, patient, you go and do muscle palpation, and you analyze the feedback of the patient according to the pain level. Am I correct?
Absolutely.
Okay.
Absolutely. So all the information you have to analyze, you put all the information back. It's like pieces of a puzzle, right? Not just one thing, it's many things. So here I do initial palpation. She has shoulder and neck pain. It's not even pain, it's discomfort. And even the temporalis, the left is painful, the right is not. But when I go inside the mouth, these muscles that do the function that will tell me something about articulation and vertical dimension, she's extremely painful. Omohyoid, extremely painful. Ligaments, so the lateral poles in rotation, extremely painful. So this girl has not a muscular problem, she has an articular problem.
Okay. So here, one of the important thing is that we need to be able to differentiate if the muscles are painful, if the joint is painful, and exactly what is painful, right?
Absolutely, because completely different treatments. You're not going to treat an arthritic joint or arthritic patient or articular patient as a muscle pain. I mean, there's no muscle. This is not just a muscular dysfunction. This is an articular problem.
Okay.
Okay.
Good.
So here it is. Here it is. Not only was she orthodontically treated, but if you look at the way the teeth, she's in a perfect class 1, and they brought the mandible back to fit the maxilla because the maxilla is fixed. She's in a perfect class 1. When you do her occlusograms, she has perfect canine function and protrudes an incisor, just like I was taught. So whoever treated her did a great job, just like me, not looking at the articulations.
Okay. So those are the intraoral pictures. Okay.
So here you can see that her low incisors and upper incisors have been grinded down because she's doing protrusive in incisors that shouldn't happen. And when she bruxes on incisors too. But when she does lateral movement, she does it on canines. And look how locked this mandible is. Look at the lingualization, or lingual inclination of the incisors.
Yeah.
So this patient wore class 2 elastics, right? Mm-hmm. This is the result of class 2 elastics. She's a class 2, treated in a class 1 by retruding the maxilla and locking the mandible in.
Okay. Do you have some? Okay, this is the occlusal pictures. Almost, yeah. If we look the arches by itself, they look pretty much aligned, right? Maybe a few teeth are faded, and maybe with aligners we can achieve the good result.
Oh, absolutely. This is a case for aligners. So they would say, if you want to align teeth, perfect. Okay, you really don't want to put aligners on these cases. Our arthritic joints and pain patients should never use aligners, ever. This is a crime.
This is a very big statement, but I agree totally with you.
If you have an articular problem, do not wear aligners. This is criminal, like it is on children. Okay. But anyway, so
These are
this
the
is in,
models. Danny, can I say something here? Taking
sure.
pictures of the models gives a few possibilities. So one of them is to have the exact angulation and three-dimensional spatial position of the upper and lower jaw, because when we take pictures, we tend to use the occlusal plane or the whatever plane to be horizontal somehow, subconsciousness. And in this way, if we have our models in articulator, we can have the exact angulation of the arches. This is one thing. And the second thing is to take pictures from inside, because this is exactly where the teeth are functioning. And this is something that if we don't have models well mounted, we don't have this information, and the case can look amazing from outside, but from inside, it's nothing is touching.
Yeah, but if you look at her, this is in ICP, so we deprogrammed her. And when she deprograms, she immediately brings the mandible forward, doesn't come more forward because it hits the upper incisors, but nothing touches in the posterior, pure incisor contact.
Okay.
And now I told you, not only do I do this, but I ask for complementary exams, of course. So here are the CBCTs. You can see that both joints, she's only 17. She's got osteophytes on both joints.
Okay.
She has a flattening slope near the eminence, so which tells me it's a lot of compression. She is a class 2. You can see the growth of the condyle facing forward. Okay. And this is a degenerative joint disease. It's progressive, loss of function. So degenerative progressive disease, it never gets better. It only gets worse if untreated.
Yeah, so this is a proof that we can have very well aligned teeth, and then we can have some of the compartments that they are suffering and they're actually losing structures.
And you can see on the CBCT that the joints are both posterior. So what I told you was she's a patient treated with class 2. So class 2 elastics do not bring the mandible forward.
Okay.
All right. On the contrary. So both her condyles are very posterior, a lot of pain, a lot of compression. Now I ask for MRIs of all my patients that have articular
Okay,
problem.
so we ask for CBCT to see the bony structures, but on the CBCT we cannot see the disc, the ligaments, if there is some liquids in the joint. So that's why we need to analyze also the other structures in the joint, in the capsule. It's actually
Absolutely.
the MRI.
Absolutely. So now I have an MRI and I can see that both sides, she's got a disc displacement with a reduction, a hypermobility, she's hyperlaxic. So on the right side and here on the left side, but more on the right side with the condyles more posterior, look, the disc is all forward. So she's got both discs displaced and with hypermobility on both joints.
Okay.
Okay.
So
Which
then,
tells me there is compression. And this
okay.
is so easy now. Look, if every doctor, when the patient walks in, just tell the patient to open and close. Look at the openings.
Fecha. Isso. Abre devagarzinho.
There's nothing straight in this movement.
Yeah.
So when I see this, of course, I'm going to ask for an MRI. So this patient has had pain before the ortho treatment. She was treated with ortho and they never cared about her pain or her dysfunction.
Okay. What else?
Okay.
Okay, so those are the occlusograms. I will join very quick for that. This is actually something that is very useful for us because we use cheap wax for creating the prosthesis for laboratory work, which is thin 0.35 millimeters. And we use this to check maximum intercuspation, which we call it ICP, protrusion, lateral protrusion left, lateral protrusion right, and also we are simulating the bruxing so we can see exactly where the wax is cut, so we can discuss and think about the interference that the patient has, right?
Absolutely. So here's and then we can match with Brooks checker. So look, what I told you, she is doing all her function on incisors with participation of canines. See?
Yeah.
So she's always, in every moment, bringing the mandible forward. This mandible is begging to be set free. It's locked in. A lot of compression in the posterior. So one of the things the muscles do is bring it forward so it stops compressing the bilaminar zone.
Yeah. So what you did in
Okay.
this case, okay, you did some posterology picture, which maybe we can skip here, we can go further.
Yeah, I just want to show you that everything that happens in the joints has an outcome in the body because it's the same muscle fascia, okay? And here's the pectus. She's got a big asymmetry. She grew this way. And this is why she did this projection. That's actually the liver. It's out of place because she's in a twisting position. She's twisted.
Yeah.
Okay, so we do condylography to every patient.
Okay.
All of my patients have condylography. Okay. So here we have the initial condyle. She's hyperlaxed, so you can see that the curves are very a lot of amplitude, right? She has no lock here. But we don't have time to go through this, but there's change in morphology, change in characteristics. So
Also
the condylography,
my
condylography will give me in numbers, so a very precise position if I'm in the hinge axis of what the problem is and a suggestion where I should take my patient. I can make decisions based on my condylography, but also my mounted models, my CBCT, my MRI, and my palpation. I need all of those, not just one. Okay, so I do ask for an X-ray after, and you can see the asymmetry is a cranial asymmetry, but also a mandibular asymmetry. You can see here in the frontal and the lateral X-ray.
So
and
for
these
us, it's very important to have the cephalometrics in the front and in the lateral, because we need to have the 3-dimensionals from the patient, from lateral and from the front, right?
100%. And you can see the asymmetry on the mandible. You see two mandibular surfaces. Patient is asymmetric. More on the left side is more, the right side is more posterior and more compressed than the right side. You can see there. And here's the panoramic that we always do. So you can see the little dots there. And this is mounting in reference position. Okay. The position that we do the condylography always in 0. So here it is. Like I told you, the first thing she does is bring it forward and nothing touches in the back. This is her reference position. There. Good. This is no tooth participation, just muscle repositioning of the jaw. So now we have, at this point, I gather all my information and I can make what we call a session of mandibular or condyle control repositioning. We are going to
so
reposition.
Here we actually have all of the patient information, and then the time for analyzing starts. So we put all of the information on the desk and we start to think and use all of the contralateral exams to validate our decision, because the way I think is that we cannot just put diagnosing based on one instrument. We have at least one more or two more totally different instruments to confirm the same problem.
Perfect. And I was asked yesterday, Mano, I had a doctor visiting, and the people that treat articular problems here in my country, we heard a live, there was a discussion between me and an expert. Remember, I am no expert. I'm a forever student. I'm still learning, but we had an expert on TMD, and he was saying, and we were having a discussion on a live, and she was remembering, he said that on children, he will sit the child in the chair, he will reposition with his hand until he feels that the child recovered the discs, and then he will make a bite in that position, construct a splint, the child will wear the splint for 3 months, and then take the splint out. And I looked at it, I said, okay, one question. How do you teach your students, with their hands or your hand? I mean, this is crazy. How do I teach my students? With numbers. Everything is reproducible, written down, everything is documented. Everything, this has to be systematic. So how do we reposition? We use toys for this. We use instruments that have a lot of precision. It's not by chance or guesstimation. I think here is good. If he loses the bite, the construction bite, he can never reproduce the splint or the position. This is crazy.
Of course. Okay. So this is very important because I know personally this case. I have some impact in this case. Can you show exactly what were your starting point for the ortho? Because we are almost
Yes.
done with the time. So yeah, we use splint here to reposition the lower jaw. After that, these are the exams that we take, extra raw pictures and some posterology pictures, but yeah, we test. So those are the MRI. So here it shows that actually recapture disc.
Bilaterally, you can see I didn't recapture the disc didn't come to the condyle. I brought the condyles to the disc.
Yeah.
Okay. So recapture after 6 months bilaterally the discs. And this is the final position for ortho.
Yeah. So here all of the symptoms are treated.
Absolutely. 100%.
So this is actually the starting point for your ortho, which looks pretty much logical right now because all of your frontal teeth upper are lingualized, also the lower, so it's normal to have a cross bite in the front, right?
Absolutely. So everything is about vertical dimension.
Okay.
She's in the wrong spatial position. So this is the starting point for the ortho. This is where she should have been treated before, and she wasn't.
Okay. So yeah, you can stop sharing a screen, Danny. You can say a few words so we don't waste any more time of the people. I think was very valuable what you show, and I think was another perspective of what we are taught most of the time and where we tend to treat our patients. So if you
I'll tell you what,
yeah,
it's nothing like we are taught. Slide check is a different world, and it changed my life. It changed my practice, and it changed the life of my patients, because today my patients are not only given the best option, the best treatment that I can give, not the best in the world, but the best that I can do. But I'm so happy because they are actually functioning well, and I can show the function. If you go in my stories, you can see an amazing case that I posted, okay, of a recovered function. And the patients are happy. And that case in my stories is actually an athlete who was losing all the games, and now it's winning the championship.
Yeah. So if you want to say a few words how the basic curriculum is going, what we are going to deliver. You are coming also for all of the modules. So people, we are going to have you here also in Bulgaria, which is amazing. I think it's great.
I don't know if it's amazing, but it's a lot of work because I put you guys to work.
Yeah.
I'll tell you what we do is, this is what I showed you guys is basic. This is basic knowledge that I didn't have. So in order to make decisions, in order to understand, like I said in the beginning, if we don't understand good function, how are we able to analyze and to understand dysfunction? We can't recognize it. We only recognize what we know. So this is basic. It's basic curriculum. It's very important because the terminology is different. The way that we think is different. Everything is different. And I believe today we are the only school doing this in the world.
Okay. So it's good the people to know that we finish around sometimes 9-10 o'clock. We are there when the job is done, not when the program is finished. So we need to finish
here in Brazil, you come with me and you teach with me here, and you've seen sometimes we stay until 11:30 at night or midnight. We start at 8:30. So whenever I never tell my students this question I'm not going to answer. I try to answer all the questions, show them, all their doubts. So I think it's a very thorough program. I think I took it twice. I took basic curriculum in Vienna twice.
Okay, Danny. So I don't know if you have something else to say. I would say thank you for your time. I know that right now it's your working hours. I know that
middle of the day.
yeah, you've got some of your of your time with the patients to be with us. So thank you very much for that. Send best regards to all of the team in Brazil and see you soon there. And yeah,
I'll see.
thank you.
Well, thank you. And I'd say join us. Come. This is a different world. And you know what? I'm very happy that I made the decision, that I was brave enough to change, because that's what it needs. It needs,
Yeah.
you know, very courageous people to do this. Okay. So come join us. All right. Come
Okay.
be part of the family. Okay. I'll see you soon.
See you. Bye.
Ciao.
Bye.